I would like to introduce our webinar speaker, Dr. Sylvie Hermouet. Dr. Sylvie Hermouet is an MD PhD Associate Professor in Hematology at the Medical School of Nantes in France. She is furthermore a hematobiologist at the University Hospital of Nantes and a researcher at INSERM, also in Nantes, specializing in the biology and diagnosis of myeloproliferative neoplasms, or MPNs, multiple myeloma, and monoclonal gammopathies of undetermined significance. Since 2008, Dr. Hermouet is a member of the European Leukemia Net. From 2009 through 2021, she was the chair of MPN and MPNR, Euronet Cooperation in Science and Technology, a new European network dedicated to the diagnosis of myeloproliferative neoplasms and hereditary erythrocytosis and thrombocytosis. Dr. Hermouet holds the 2020 International Myeloma Foundation Brian D. Novis Research Award and the 2021 International Myeloma Foundation Black Swan Research Initiative Award. The title of her presentation is Determination of the Target of Monoclonal Immunoglobulins Using the MIAA Assay, a Novel Diagnostic Tool for Monoclonal Gammopathies. Sylvie, I'm virtually handing the cursor over to you. Please take it away.
Thank you very much. And thank you particularly for giving us the chance to present our work and the new assay that we developed in order to determine the target of monoclonal immunoglobulins. So first, I want to describe what monoclonal gammopathies are for those who are not familiar with this disease. We distinguish three stages. The first is monoclonal gammopathy of undetermined significance, or MGUS. And this is characterized by the presence of the so-called monoclonal immunoglobulin. You can see that on a serum protein electrophoresis on the right part of the slide, the green peak corresponds to albumin, and normally the immunoglobulins are in the gamma zone. And in case of monoclonal immunoglobulin, then there is a peak here that is presented in red on the slide. And when it's below 30 grams per liter, then we are in at the MGUS stage. The second stage is smoldering multiple myeloma. That's an intermediate stage between the MGUS and the myeloma stage. So the third stage is multiple myeloma, and this is a highly malignant blood disease. And in that case, the monoclonal immunoglobulin is above 30 grams per liter. More precisely, MGUS is a quite common, or at least it's not a rare condition, because it might affect up to 5% of the people over the age of 50. So that's about 1 million people in France and more than 5 million in Europe, and a similar frequency in the US. And by definition, as I said, monoclonal immunoglobulin should be below 30 grams per liter in blood serum in the context of MGUS. And the plasmacytic clone that produces this immunoglobulin should represent less than 10% of bone marrow cells. At this stage, the patients, well, they are not patients, they are considered healthy. They do not present any symptoms, and so they are not treated. The monoclonal AG is simply monitored every 6 or 12 months. However, the risk of transformation toward the highly malignant myeloma is considered to be at least 1% per year per patient. And therefore, it means that if there is an evolution over 20 years, you have a 20 to 30% risk of progressing toward myeloma. At the myeloma stage, by definition, the monoclonal AG quantity is above 30 grams per liter, and the plasmacytic clone represents more than 10% of the bone marrow cells. You can see on the right part of the slides healthy plasmacytes above, so at the MGUS stage, and the lower picture shows malignant plasma cells at the myeloma stage. At the myeloma stage, patients are symptomatic. They present what we call the CRAB symptoms, and CRAB stands for hypercalcemia, renal or kidney insufficiency, anemia, and bone lesions, which are quite frequent, especially in the skull, as represented in the picture at the bottom of the slide. At this stage, a patient receives intensive therapy, mainly chemotherapy, and the aim is to suppress the plasmacytic clone. However, these treatments are not curative, and the median survival presently is about 6 to 7 years. Well, in medicine in general, to be curative, you have to know the cause of the disease. And unfortunately, for MGUS and myeloma, no cause has been really identified. And another remark I would like to make is that although the patient's monoclonal AG is a major marker of MGUS and myeloma disease and critical for the diagnosis, for the longest time, monoclonal immunoglobulins were assumed not to have any antibody function, and typically they were not studied at all. We thought differently. Our rationale was rather simple. Typically, immunoglobulins are produced to fight infections. And in fact, chronic infection that was undiagnosed at the MGUS stage would explain the inflammation observed in MGUS and also in myeloma. So our working hypothesis was that for subset of patients, the monoclonal AG may target antigens from infectious pathogens. And we decided to try to set up a new assay that we could use to determine whether a monoclonal AG targets an infectious pathogen, and if possible, to identify the protein that was targeted. So we had arguments to think that this hypothesis could be real. First of all, as you all know, when we fight infections, we first produce polyclonal immunoglobulins, but then it's not rare after a while that there is a restriction, and we then produce oligoclonal immunoglobulin, and in some cases, a monoclonal immunoglobulin is produced. By definition, it should not last more than 6 months, because if it lasts more than 6 months, then it's no longer a normal response to infection, and then we move to the MGUS stage. And then it's well established now that even at the MGUS stage, there are already genetic alterations, but over the time, if the plasmacytic clone persists, more genetic alterations are acquired, especially in the genes that encodes for IG chains, and then the patient progresses towards smoldering myeloma and then overt myeloma. So we were quite enthusiastic when we started this project, because we thought that if we knew the target of the monoclonal AG of the patients, then this would indicate what was the initial event of a clonal gammopathy. And if we knew that, we could propose to treat the target of the monoclonal AG if it was possible. And in case of infectious pathogens, then you could propose antiviral drugs or antibiotics. And hopefully the idea was to stop the stimulation of clonal plasma cells and then reduce the production of monoclonal AG, and hereby preventing evolution toward multiple myeloma. We had some results, in fact, to support this hypothesis. 20 years ago, we reported a case of a young man who presented with plasma cell leukemia. And this man was infected both by hepatitis virus and human herpes virus 8. And we were able to purify the monoclonal AG of this patient. And we tested it against hepatitis C virus and HBV-8. And as you can see in the immunoblots, the monoclonal AG of these patients specifically reacted with the core protein of the hepatitis C virus, HCV. This was really a side project at the time, and it took us some time, actually 5 years, to collect patient sample and information about the patients. So we were able in 2008 to report on 11 cases of patients who had been infected with HCV and who developed later either an MGUS or multiple myeloma. And we found that for 9 of these patients, so 80%, the monoclonal AG targeted HCV and most of the time the core protein. So we thought that in some cases, indeed, we should be able to detect a pathogen, possibly at the initial cause of either MGUS or multiple myeloma. There was another set of data that supported our hypothesis. We also work on inflammation, and we were able to study the cytokine profiles of 68 MGUS patients and 74 myeloma patients. And we measured, we quantified 40 cytokines linked to inflammation using the Luminex technology. And we found that 36 of the 40 cytokines were elevated similarly in MGUS and in multiple myeloma. And if you remember, MGUS is a benign stage. The patients do not have any symptoms. To the opposite, myeloma is highly malignant, and yet we had the same level of inflammation except for 4 molecules. So this is also consistent with the possibility of an infection at the MGUS stage that would be undiagnosed, but that could explain the inflammation. So we started by purifying the monoclonal AG. So this means separating the monoclonal AG from the other immunoglobulins in the serum of patients. And this is really necessary to do because even in the case of myeloma, many people think that there are very little polyclonal immunoglobulins left in myeloma patients, but in fact, there are some, and we have to be sure we work only with the monoclonal AG. So the way we do this, we do a regular serum protein electrophoresis. And as you can see, there are 2 main bands in case of MGUS or myeloma, the albumin at the bottom and at the top on this slide, the monoclonal AG. So we carefully cut the band from the gel, the band that corresponds to the monoclonal AG. We elute the protein from the gel, and then we verify the purity of the preparation by running an isoelectric focusing. And as you can see, in case of serum, you have a smear, and you also have several dark bands that corresponds to the monoclonal immunoglobulin. And in the preparation of purified monoclonal AG, you only see the top 3 bands. In case you wonder, there are 3 bands by isoelectric focusing because the monoclonal immunoglobulins of patients have different degree of sialylation, and this is represented by different bands by IEF. The second step, once the monoclonal AGs have been purified, is to incubate them on the multiplexed infectious antigen microarray. So we say MIAA assay. So this assay is based on the protein array technology. We spot on the array proteins. Whenever we can, we use recombinant proteins from viruses or bacteria. When we count, we use lysates. This is the case for Helicobacter pylori, for instance. And the choice of the infectious pathogens that we put on the array has been decided. We decided to choose pathogen that cause latent infections. Typically 10 pathogens are present, spotted in triplicate on the assay, plus the negative and positive controls. We incubate the purified monoclonal AG on the pad, and we always run in parallel the serum of the patient. Then we wash, and then we reveal by incubating with a secondary antibody against human IG. And this secondary antibody is labeled with fluorescence, green fluorescence. So this is the result. The result you see on the right part of the slides corresponds to the signals you get with serum. We have many different immunoglobulins directed at different pathogens in the serum, and so we always get many signals, even in patients. So this assay was first published 10 years ago, and in 2018 we got a patent from the US office, and last year from the European office. Now we have identified 7 pathogens that are the targets of monoclonal AG, AGG or AGA from MGUS, smoldering myeloma, and myeloma patients. There are 6 viruses: EBV, herpes simplex virus 1, CMV, varicella zoster virus, and 2 hepatitis viruses, HCV and HBV, and 1 bacteria, Helicobacter pylori. Using a different approach, we also identify the DP1 code protein of a family of human enteroviruses as targets of monoclonal immunoglobulins. I will describe that in a few minutes. So these results have been published first in 2017 and in 2020 and 21. So these are typically the results you get with the MIAA assay. On the top part of the slides, you have a negative result. The purified monoclonal AGG doesn't recognize anything on the array, so there is no signal at all. With the serum, as usual, you always get different, many signals, always in triplicate. For patient 3, you can see that the monoclonal AGG recognizes EBV, EBNA1 in that case, a triplicate dots. And for patient 4, the signals represent HSV1. So this monoclonal AGG binds to HSV1. This is another way we present our results, maybe more informative. On the serum part of the figure, you have many signals. The different colors correspond to different pathogens. And you can read the level, the intensity of the signals on the y-axis. And when you look at the results obtained with a purified monoclonal AG, you can see here only one color that corresponds to EBV, and in fact EBV EBNA1. There is the triplicate is visible for the for patient 16. It's not because dots are superimposed for patient 63. Now, on the E part on the right of the slide, this is to show a typical result obtained for Helicobacter pylori. Again, in the serum, many signals because the patient has antibodies against different pathogens, and the purified monoclonal AG from these patients gives signals for Helicobacter pylori. And there are several colors because we have several different lysates of Helicobacter pylori. And then this is typical results for HCV. These are 3 patients who have each monoclonal AG that targets HCV core, the dark red signal. You can see the triplicates well. And one patient targets the NS4 protein of HCV. This is the pink signal. Now we have studied actually a little more than 400 patients. And this cohort includes 155 MGUS patients and 147 myeloma patients. We also studied smoldering myeloma patients, and some of them are included in the total, but I cannot show you the detail of the smoldering myeloma patients because this is still ongoing, and an article is in preparation, but not published yet. So globally, we were able to identify the target of 61% of patients, and this means up to 77% of patients in MGUS and a little less than 50% in multiple myeloma. If we look at the detail, you can see that the target of the monoclonal immunoglobulin was an infectious pathogen for about 50% of patients, 61% in MGUS, and 1/3 of myeloma patients. The most frequent target was EBV, and especially the EBV1 protein, 1/4 of patients in myeloma and 1/3 in MGUS. After this, CMV was, well, not frequent really, but not rare, 4.5% of patients. And this is actually observed only in MGUS and smoldering myeloma, never in our myeloma cohort. HBV1 was also observed essentially in MGUS and much more rarely in multiple myeloma. For the 3 other infectious pathogens, the frequency was similar in MGUS and myeloma, about 2% for Helicobacter pylori, again 2 to 3% for varicella zoster virus, and about 1% for HCV. So if we think that the target indicates the initial event of MGUS or myeloma, then infection-initiated MGUS and myeloma are not rare. They're actually a majority in MGUS. And it appears from our cohorts that infection pathogens are initiate MGUS much more frequently than multiple myeloma, which may indicate that infection-initiated MGUS do not necessarily progress toward multiple myeloma. And this seems to be especially true for CMV and herpes simplex 1, because we didn't find this in multiple myeloma. So maybe CMV and HSV1 associated MGUS are at low risk of transformation toward myeloma. So of course, this has to be confirmed in large studies and especially in prospective studies if possible. Another remark that we made was concerned multiple myeloma patients who had monoclonal AG that targeted EBV-1, because we found that this group of patients had a more important invasion of bone marrow by the clonal plasma cells, and they had a poor kidney function, higher creatinine level, and also a higher beta-2 microglobulin level, which indicates greater inflammation and greater severity of disease. For some reason, this group was essentially men. 90% of the patients were men. So there is a possibility that EBV-associated myeloma could be a more severe form of myeloma disease. Now, let's speak of enterovirus VP1 proteins. We found that about 5.5% of patients have a monoclonal immunoglobulin that targets VP1, and this is 8% in MGUS and only 2% in multiple myeloma. So also a difference between myeloma and MGUS. The way we identified this target was different. We had a number of monoclonal AG that for which we could not find any target using the MIAA, and we send, I don't remember exactly, but 15 or 20 of these monoclonal AG to PEPperPrint to be analyzed by the PEPperCHIP Infectious Disease Epitope Microarray. And this array is constituted of 3,760 linear BCL epitopes from 196 infectious pathogens. And on these arrays, the same sequence can be present in different peptides. So you can have several peaks for even for a monoclonal immunoglobulins. If you look at patient 438, for instance, you can see that the sequence PALTA A, ETG or appears several times. And for patient 478, this sequence or the sequence PALTA ETG also appears. And these sequences are found in the DP1 code proteins of human polioviruses type 1 and 3. And the second sequence is found in the DP1 code protein of Coxsackie viruses type B1 and B3. So we were happy to have these results, and we decided to confirm them using dot plots. So what we did, we ordered a series of peptides, the relevant peptides corresponding to the exact sequence of human polioviruses 1 and 3, and the others to Coxsackie viruses B1 and B3. And also a set of irrelevant peptides where we modified 2 amino acids in the critical sequence. And then we realized dot plots. You may see A, B, and C on the dot plots. The A line corresponds to the relevant peptides, so with the exact DP1 sequence. And the B and C lines corresponds to the irrelevant peptides, so that we use as negative controls. And as you can see, the B and C lines do not give any signals as expected. And on the A line, you can see signals, some strong, some not very strong, and either indicating a reaction with the DP1 protein from poliovirus 1, and sometimes 1 and 3, or the Coxsackie virus, depending on the patients. So this is confirmation that these DP1 proteins are indeed, can be targets of monoclonal AG, both in MGUS and particularly in MGUS patients. And so this was published in 2021. While we were doing these studies, a group at Yale University, led by Madhav Dodapkar, was working on Gaucher disease patients. And this disease is a congenital disease characterized by a deficiency in the glucocerebrosidase enzyme. And these patients accumulate glucosylsphingosine, so a glucolipid, in all their tissues. So they have a number of all kinds of many different symptoms, but it was well known that these patients, Gaucher disease patients, were at higher risk of developing an MGUS or a myeloma. And Madhav Dodapkar and his group put the hypothesis that the monoclonal AG from these patients would target glucosylsphingosine. And this is what they demonstrated in their paper that was published in the New England Journal of Medicine in 2016. And they also showed that this was not limited to Gaucher disease patients with MGUS or myeloma, that this was true also for patients with a sporadic MGUS or multiple myeloma. So patients, MGUS or myeloma patients who didn't have Gaucher disease. So when this was published, of course, we set up an assay, a glucosylsphingosine assay, adapted from the one described by Dodapkar. And we confirmed that indeed about 15% of MGUS and myeloma patients have a monoclonal agent that targets glucosylsphingosine. So if we look now at the completed table, you can see that so we reached the total, and glucosylsphingosine is indeed a target for about 12% globally of patients. I'm sorry, I had forgotten to say that the DODAP-CARS group described the patients with a monoclonal AG that target glucosylsphingosine as having a mild form of myeloma, and this was also confirmed in our studies. Again, these are small cohorts, so these observations need to be confirmed in large cohorts. So I hope that you can see that there is an interest in knowing the target of monoclonal AGs, first for the prognosis, both in MGUS and in myeloma. As I said, the diagnosis currently of MGUS, smoldering myeloma or myeloma is made essentially by quantifying the monoclonal, detecting, then quantifying the monoclonal AG, and then knowing the number of plasma cells in the bone marrow. We hope that determining the target of the monoclonal AG will soon become part of the diagnosis of this disease. This can be done obviously using the MIAA assay and with the glucosylsphingosine assay. And this should have some interest for prognosis in myeloma, because the preliminary results that we have show that EBV-associated myeloma seem to be a more severe form of disease. In contrast, glucosylsphingosine-associated myeloma seems to be a mild disease. And in the context of MGUS, it seems that MGUS associated with enterovirus VP1, CMV, or herpes simplex virus 1 apparently rarely evolved toward myeloma, so this should be reassuring for patients. Of course, there is an interest, well, there should be an interest for therapy, because if we know the target, then it becomes well, a target for therapy, especially antiviral drugs or antibiotics. And this actually works. The first evidence that target-reducing therapy works was provided by the DODAP-CAR group in 2020. They obtained complete remission in patients, in Gaucher disease patients who had the monoclonal agent that targeted glucosylsphingosine by reducing the level of glucosylsphingosine, which is actually a typical, well, not typical, but part of the treatment of Gaucher disease. And they obtained complete remission in one case of MGUS and one smoldering myeloma. We were interested in knowing if antiviral treatment would be efficient in HCV-associated myeloma. And we were confident that it should, because if you remember, 80% of HCV-positive MGUS and myeloma patients have a monoclonal agent that targets the virus. So this would indicate that the virus is really at the beginning of the disease. And we were able to do that, to demonstrate that in collaboration with Professor Joaquin Martinez-Lopez and his team in Madrid. They had a myeloma patient who was refractory to all the classic treatment of myeloma for several years. This patient never responded to any treatment. Then it was found that this patient was positive for HCV, and we were able to demonstrate that her monoclonal AG targeted HCV core and the C1 fragment of HCV. She received antiviral therapy, which was efficient. And as you can see, the monoclonal AG decreased and disappeared completely 3 years in 2017, and the plasmacytic clone disappeared also. So this patient has been in complete remission since then. We were also able to study several MGUS patients, and similarly, these patients have, we showed that the monoclonal AG of these patients targeted HCV, except for one who had light chains Benjamin's disease. And as you can see, when they received the antiviral treatment, the viral load decreased for all the patients. This is the A part of the figure on the right, and on the B part shows the decrease of monoclonal AG corresponding to the decrease in viral load. For two patients, there is a clear decrease in monoclonal AG. For two, there is a stabilization of the amount of monoclonal AG, and the one for whom there is no decrease or stabilization had light chains that did not recognize the virus. So these results on the efficacy of antiviral treatment in the context of HCV-associated monoclonal gammopathies was published last year. And this prompted us to look at HBV-associated MGUS and myeloma. So we were able to study 18 patients infected with HBV, 6 MGUS and 12 multiple myeloma, and we studied the monoclonal AG of these patients using the MIAA confirmed by dot blots and also with the glucosylsphingosine assay. As you can see, 11 patients had a monoclonal AG that targeted HBV, so that's about 61% of patients. The results are shown on the right part of the slide. The monoclonal AG gives only one signal, and that is HBV. And for patient 4, it's the E antigen that is recognized by the monoclonal AG, and for patient 6, it's the X protein. As you can see, the other patients had a monoclonal AG that targeted either EBV, HSV1, Helicobacter pylori, or glucosylsphingosine for one case. Regarding the HBV proteins recognized by the monoclonal immunoglobulins, the most frequent was HBV-X. And it's interesting because this protein plays a central role in the initiation and maintenance of viral replication. In a way, it makes sense. We were also able to analyze the statistic of large cohort of myeloma patients, also in collaboration with our colleagues from Madrid. In orange, you can see data from the HBV positive cohort, and in blue, the HCV positive cohort. And we compared the overall survival at 3 years of patients who received antiviral treatment compared to those who did not receive antiviral treatment. And as you can see on the curve, the purple curve shows the results of patients, the survival at 3 years of patients who received antiviral treatment. And you can see that it's significantly better than those who did not receive antiviral treatment. And this was true both for the HBV positive cohort and the HCV positive cohort. And I remind you, these are myeloma patients. So this work is in Press Hematologica, and it should be published in the coming weeks. So in conclusion, thanks to the MIAA, plus the glucosylsphingosine assay, it's now possible to determine the targets of monoclonal AGs from the majority of patients diagnosed with MGUS, smoldering myeloma, and myeloma. Knowing the target of the patient's monoclonal AG is useful in terms of prognosis and therapy, and target-reducing therapy is beneficial to both MGUS patients in terms of preventing myeloma and to myeloma patients because there is improved survival and improved response to myeloma treatment. Finally, the efficacy of target-reducing therapy is demonstrated for glucosylsphingosine in MGUS and smoldering myeloma, and for HCV and HBV for MGUS and myeloma. And studies of the efficacy of treating Helicobacter pylori for patients, smoldering myeloma patients who have a monoclonal AG that targets Helicobacter pylori is ongoing. And this is a collaboration with the iStop Myeloma Consortium led by Professor Sigurdur Kristinsson in Reykjavik in Iceland. And these studies are supported by the International Myeloma Foundation. So if you look at the figure on left part of the slide, you can see that for MGUS, at least in our cohorts, 60% seem to have an infectious origin, and you can act on these MGUS using antibiotics or antivirals, and then stop or reduce the risk of evolution toward myeloma. And you can also act on at the myeloma stage because the survival of patients is improved. Now, I just want to thank the people who worked on this project. Edith Bigot-Corbel, who worked with me from the start, so 20 years now. Jean Hart, who came later, but whose advice was very useful. Delphine Ferrand, who set up the MIAA, and Adrien Bosbeu, Sophia Lamaillet, and Nicolas Ménesson, who studied the hundreds of patients that have been described today. And this work was done in INSERM labs, first at the CRC in Nantes, and now at Insight also in Nantes. And I need to thank the many French collaborators, Cathy Charlier and Pierre Degel in Nantes, Yannick Jacques, Eric Piver and Anne Tallet à Tours, in Tours, Olivier Decaux in Rennes, Laurent Garderet in Paris, François Giraudon, Denis Caillot in Dijon, Eric Lippert in Brest, and Olivier Mancier in Bordeaux. And many thanks to our Spanish colleagues, Joaquin Martinez Lopez, Maria Linares, Alba Rodriguez Garcia from the University Hospital of October 12th in Madrid. So thank you very much for your attention.
Great. Thank you very much, Sylvie, for this very comprehensive presentation. So we have, in the meantime, received one question. I'm going to read it to you. And the question is, have you analyzed the specificity of IgM paraproteins from patients with Waldenstrom's macroglobulin anemia using this technique?
No, we have not. The reason is that IgM are very big molecules, and so far they are very difficult to purify for us. We concentrated on AGG and AGR. I think we tried to purify one or two IgMs, but this was not very successful, and so we have not really. Well, we have not tried further. That's where we are. So I think either we have to start by selecting patients who have a very, very high amount of IgM, and so that we are not bothered by contaminating polyclonal AG, or we have to find a way to purify AGM sufficiently to be able to study Waldenstrom's patients.
Great, thank you. Are there any more questions from the audience? So once again, please use the Q&A box to type your question. Let's give it maybe another minute. So the fact is that there are so few questions indicates that everything was very well explained.
Wow.
Great. So if there are no further questions, let's begin and wrap this up. Thank you all for attending this webinar presentation. And we also want to thank again our speaker, Dr. Sylvie Hermouet. We will make this presentation slide and webinar file available shortly. If you have any questions, please contact the PEPperPrint team directly. Feel free checking out our website for updates, future events, and webinar announcements. I will end this webinar now. Thank you again for everyone for dialing in and your interest, and see you all next time.
Thank you very much.